Welcome back to the new section on steroidogenic defects. Steroidogenic defects are one of the most fascinating topics in the entire endocrinology, and at the same time, from the student's perspective, it's very complicated topic, and from the teacher's perspective, it's a very challenging topic to even attempt to explain to a particular student. So without wasting much time, let us go and discuss on the steroidogenic defects in detail, and we're going to divide and classify the steroidogenic defects and going to understand each and every bit of steroidogenic defects, and with special preference to the 21-hydroxylase deficiency, which is going to be the most common steroidogenic defect in the entire world. And 21-hydroxylase deficiency is also the most common cause of congenital adrenal hyperplasia in the entire world. So let us start with the basics first. The first point I want to tell in steroidogenic defect is the fact that this aldosterone output from the zona glomerulosa of the adrenal gland is dependent on this particular enzyme's activity, that is aldosterone synthase, which has multiple functions and multiple actions, which you have seen in the previous video itself. And you also have to know that this aldosterone synthase enzyme is in turn under the control of this angiotensin 2 and potassium. This angiotensin 2 is further under the control of renin. So I can write the fact that this aldosterone synthase enzyme is under the control of this renin-angiotensin axis. So this renin-angiotensin axis is further under the control of the volume status in the body. Suppose if the volume status in the body is low, if the patient is having salt wasting or hypovolemia, it's going to stimulate the renin-angiotensin axis, which is going to have more of renin and more of angiotensin 2, and which is going to stimulate the aldosterone synthase enzyme, which is going to further increase the aldosterone output from the zona glomerulosa. And at the same time, if the patient is having high volume status, for that matters, if the patient is having salt retention in the body, this will try to inhibit or suppress the renin-angiotensin axis, which is going to try to suppress the renin and angiotensin levels, which is in turn going to try and suppress the aldosterone synthase enzyme, which is going to suppress the aldosterone output from the zona glomerulosa. But one key point to understand is the fact that ACTH is not going to regulate the aldosterone output from the zona glomerulosa. It's always the renin-angiotensin axis that is completely going to control the aldosterone output from the zona glomerulosa and not ACTH. But what is the role of ACTH? ACTH is a general tropic hormone. I'm not denying that fact. ACTH stimulates the glomerulosa. But even though the aldosterone output is under the control of renin-angiotensin axis, but ACTH does stimulate the glomerulosa, ACTH does stimulate the fasciculata, and ACTH does stimulate the reticularis as well. Clear? So whenever you are going to have excessive ACTH due to any reason, so it's one of the trophic hormones, as I told you. So this excessive ACTH is going to stimulate the adrenal glands, and this excessive ACTH is one of the main reasons why you get this adrenal hyperplasia in the first place. So one of the important prerequisites for getting adrenal hyperplasia is the excessive ACTH, point number one. But at the same time, many of the congenital adrenal hyperplasia conditions, you would have seen that the substrates are increasing that are proximal to the enzyme defect. For example, let us take a simple example, that is a 21-hydroxylase deficiency, where the patient is not having 21-hydroxylase. Anyway, we are going to discuss in detail in the coming few minutes, but let me tell you what is the importance of ACTH here. So in this 21-hydroxylase deficiency, obviously your cortisol output from the adrenal gland will be low. The cortisol output from the adrenal gland is low. It's going to stimulate the pituitary gland because it's going to give a strong feedback to the pituitary, and the pituitary will definitely increase the ACTH output. And this excessive ACTH, as I told you, is the main reason why you develop this adrenal hyperplasia in the first place. And this excessive ACTH is also the main reason why lot of other pathways in the adrenal gland is stimulated, and you are producing this excessive substrates, right? You might argue the fact that it's because of the defect in the 21-hydroxylase or defect in the enzyme, the substrates that are proximal to the enzyme defect has to increase. Yes, but why such a massive increase? The massive increase that you encounter in this substrates that are proximal to the enzyme defect is primarily due to the excessive ACTH. That also explains the fact that in few conditions where ACTH may be normal, even though you have an enzymatic defect, the substrates may not be increased that much. It may be normal or it might be just mildly increased, but it not be massively increased like what you see in patients with congenital adrenal hyperplasia. So the main player that increases these substrates and helps in our biochemical understanding is the fact that ACTH levels are elevated. That is the main reason why you have this increased substrates that are proximal to the enzymatic defects. So this is concept number 2, which means I can finally come to a conclusion that the glomerulosa's aldosterone output is under the control of renin-angiotensin axis, and the cortisol and the sex hormone output from the adrenal gland is under the control of ACTH. Clear? Or the glomerulosa's output is under the control of renin-angiotensin axis, and the fasciculate and reticularis output is under the control of ACTH in the first place. So the next point that you have to understand, the third basic that you have to understand is the fact that whatever I have painted in yellow, that whatever I have color coded here in yellow, which means these are the enzymes that are common for both adrenal as well as gonadal steroidogenesis, which means defect in these enzymes is going to result in problems of both adrenal as well as gonadal steroidogenesis. For example, I can say if you have a star deficiency, or if you have a side chain cleaving enzyme deficiency, otherwise referred to as desmolase enzyme, or if you have a 3-beta HSD2 deficiency, or if you have a 17-hydroxylase or a lyase deficiency. 17-hydroxylase and lyase belong to the same enzyme, same gene. So if you have these defects, it's going to affect both the gonadal as well as the adrenal steroidogenesis. Clear? That's very, very important. And almost every single condition which I have mentioned here in the 4 enzymes which I have told which are defective, in these conditions definitely there will be adrenal hyperplasia, because cortisol output in these conditions will be surely low. There is no doubt about that. But on the other hand, if you have a defect in 21-hydroxylase, or if you have a defect in 11-beta hydroxylase, otherwise called as 11B1 enzyme, or if you have a defect in aldosterone synthase enzyme, otherwise referred to as CYP11B2, these defects will affect only adrenal steroidogenesis, and it's going to spare the gonadal steroidogenesis, because these enzymes are not important for gonadal steroidogenesis. Clear? Gonadal steroidogenesis will be spared. But peculiarly, this CYP11B2 deficiency, that is this aldosterone synthase deficiency, will not result in adrenal hyperplasia. That's a very important point. This alone will not result in adrenal hyperplasia. Why this will not result in adrenal hyperplasia? Because even though in aldosterone synthase deficiency, your aldosterone levels will be grossly decreased, but this aldosterone is not going to give feedback to the pituitary. Patient will have salt wasting because of low aldosterone, but they will not result in excessive ACTH. So these patients will not having adrenal hyperplasia, and these patients will not be having excessive ACTH, which means they will have normal ACTH, and they'll have, because they have normal cortisol, and because of the normal ACTH, there will be no hyperplasia of the adrenal gland, and because they have normal ACTH, there will be no hyperpigmentation as well. So this excessive ACTH is one of the main reasons why you develop this hyperpigmentation in the first place, which means these defects, star defect, side chain cleaving enzyme defect, 3-beta HSD2 defect, 17-hydroxylase or lyase defect, all these things are going to result in hyperpigmentation and adrenal hyperplasia because of elevated ACTH. But this 11B2 deficiency will not result in elevated ACTH and hyperpigmentation and adrenal hyperplasia in return. On the other hand, this 21-alpha hydroxylase and 11-beta hydroxylase deficiency will surely result in low cortisol, and it's going to result in elevated ACTH, which means these conditions will be surely again associated with adrenal hyperplasia and hyperpigmentation. Clear? These are very, very important concepts to understand. Similarly, I told you the enzymes which I have shared in green here, especially this 11-beta HSD and this aromatase enzymes. So these are completely important only for the gonads, and they are not important in the adrenal glands. Which means what I am trying to tell is the fact that if you have a 17-beta HSD deficiency, or if you have a aromatase deficiency, and this is going to affect only the gonadal steroidogenesis, and they are going to spare the adrenal steroidogenesis. Which means in these conditions, patients may have disorder of sexual differentiation but they may not have any adrenal issue at all, which means in these enzyme deficiencies, the adrenal steroidogenesis will take place normally and the patients will not have any salt wasting, or patients will not have any low cortisol, which means the patient will have a normal cortisol and patients will have a normal ACTH because they have normal cortisol, and the patients will not have any adrenal hyperplasia and the patients will not have any hyperpigmentation as well. So this is a very, very basic thing to understand in the first place. Clear? So 17 beta HSD3 and aromatase will not affect the adrenals at all. Similarly, 21 hydroxylase, 11 beta hydroxylase and aldosterone synthase deficiencies will not affect the gonads at all. Whereas your star deficiency, side chain cleaving enzyme or desmolase deficiency, then 3 beta HSD and 17 hydroxylase deficiency is going to affect both the adrenal as well as the gonadal steroidogenesis. If they ask you where you don't have hyperpigmentation, where you won't get adrenal hyperplasia, where the ACTH levels will be normal despite steroidogenic defects, answer will be 17 beta HSD3, aromatase deficiency or aldosterone synthase deficiency. So these are 3 enzymes which will not have hyperpigmentation because they have normal ACTH and they don't have adrenal hyperplasia as well. Clear? So how do you develop? This is the 4th basic point I want to tell. This we have discussed in the previous videos itself, but I want to tell how you develop a DSD in the first place. Please avoid the terms ambiguous genitalia. Please avoid the terms intersex. Always go for the beautiful term called disorder of sexual differentiation. That is the best term to be used. So we know in a female, so this XX means it's genotypically a girl. So what they need to become a girl? Phenotypically. So if you want to become a phenotypic girl, you just need only one thing. You don't need any androgenic effect. That's all. If you just leave them without any androgens, they are going to become a female phenotype. So what makes a DSD in a XX karyotype? So it's the influence of the androgens. If you have androgens exposure, that too at that particular period of 8 to 13 week window, which I already described in the basics. So this females are going to get virilized and they're going to develop this disorder of sexual differentiation. And the most important fact is the thing that these girls, irrespective of whether they have estrogens or not, in the embryonic life, it doesn't matter. It's always whether they become a male phenotype or a virilized phenotype or a female phenotype without virilization, it depends on the exposure to the androgens. That is why I always tell this XX, disorder of sexual differentiation, is always the act of commitment. Commitment in the sense, here I mean by androgen exposure. So if they have androgen exposure, they develop disorder of sexual differentiation. But on the other hand, in a male, for example, they are genotypically males. So what you need to become a phenotypical male? To become a phenotypical male, you need this adequate amount of androgens, which means these androgens has to be adequate. Correct amount of androgens, both testosterone as well as dihydrotestosterone, is required for this XY karyotype to become a male phenotype, which means they normally have to be virilized. That's what we call it as a normal virilization. Clear? Suppose if you do not have this adequate androgens, which means if you have low androgen exposure, especially during that window period of 8 to 13 weeks, as I have explained in the previous videos, these XY males will be under-virilized. Because they are under-virilized, their labioscrotal fusion may not be complete and the penis may not be in correct size, and they will be resulting in a disorder of sexual differentiation, which you generally, by colloquial term, you call it as ambiguous genitalia. So that is the reason I tell, if you want to develop a XY DSD, it's always an act of omission. What I mean by an act of omission here is poor androgen exposure, which means you are omitting the androgens here. There you are committing with the androgens in XX DSD, whereas in XY DSD you are omitting the androgens, which means poor androgen exposure. That is the reason for XY DSD. Which means final take home point, so to get a XX DSD, you need excess androgens that are given to the female child, or to get a XY DSD, there will be a poor androgen exposure to a male fetus. That's all. So this is the basis of getting a disorder of sexual differentiation, or in colloquial terms you call it as ambiguous genitalia. So with these basics, let us try to understand this 21 hydroxylase deficiency in the first place. So remember, this 21 hydroxylase deficiency contribute to 95% of the cases of congenital adrenal hyperplasia as well as the entire steroidogenic defects in the world. So which means it is the most common and the most important that you have to understand for exams. That's why I'm going to discuss that in the first place. And what are the metabolites that will be increased? What are the metabolites that will be decreased? All these things will be decided based on the action of ACTH, and at the same time, what is the enzymatic defect and what is the level of enzymatic defect. So let us go and see what will happen in a classic form of congenital adrenal hyperplasia of 21 alpha hydroxylase deficiency. So remember, all the congenital adrenal hyperplasia are enzymatic defects, which means almost everything will be autosomal recessive. There is no doubt about that. And the gene, we know very well, it is CYP21A2 gene. We have described this multiple times in the previous video itself. And this gene is present in chromosome number 6. So all these are questions in exams. Clear? So we are going to discuss right now the classic form of congenital adrenal hyperplasia of 21 hydroxylase deficiency. Clear? So there are some non-classic forms also, which I will be discussing in a few while. But right now we are going to discuss on the classic 21 alpha hydroxylase deficiency. So this image will show you where is the defect. So I have marked in red. So this is the defect. Here the 21 alpha hydroxylase is the enzyme that is defective, which is not working. So by common sense, it's very clear that your deoxycortisol levels will be low and the cortisol levels will be low. And obviously this cortisol levels is going to give feedback to the pituitary because there is low cortisol. So this is going to stimulate the pituitary to produce excessive ACTH. And that is the reason these patients will definitely have hyperpigmentation. No doubt about that. And this excessive ACTH is the main reason why you get hyperplasia, because this is going to stimulate the adrenal glands by its trophic effect. And at the same time, your deoxycortisone levels will be low. Remember, deoxycortisone has little mineralocorticoid activity, not powerful like aldosterone, but still they do have a decent mineralocorticoid activity, but still it will be low. Corticosteroid levels will be low and aldosterone levels will be low, and 18-hydroxycorticosteroid levels also will be low. So which means what's happening to the net mineralocorticoid output? It is decreased. And what's happening to the net glucocorticoid output? That is also decreased. There is no doubt about that. But what will happen to the sex hormone output? That's what you're going to see here. So glucocorticoid output will be decreased as well. That's why the ACTH is high. But what will happen to the adrenal androgens? We know that ACTH is stimulating the gland very badly, and all this process will be accelerated. So which means you are going to have serious elevations in this substrate that is immediately proximal to the gland. You can see this 17-oxyprogesterone is the one that's a very, very important substrate and very important biochemical test as far as your 21-hydroxylase deficiency is concerned, because of two reasons. One, because of elevated ACTH that is going to increase all of these substrates. At the same time, this 17-oxyprogesterone is the most important because it's immediately proximal to the enzymatic defect. Coupled with elevated ACTH, this in classic forms, this 17-oxyprogesterone is going to tremendously elevate, and that's going to serve as a biochemical marker for us for the diagnostic purpose as well. So this excessive accumulation of the substrates proximal to the defects coupled with excessive ACTH action is going to produce this excessive amounts of androgens, DHA and androstenedione. But remember, since I told you this 21-hydroxylase deficiency is not going to affect the gonadal steroidogenesis, the gonads are nice and good functioning. So I can write the gonadal steroidogenesis will be completely normal. They are normally functioning. There is no doubt about that. So let us go and describe what will happen to the mineralocorticoids. The mineralocorticoids will definitely be low. All the mineralocorticoids will be low, which means I'll be having low deoxycorticosterone and low corticosterone as well as low aldosterone. There's no doubt about that. And what about the glucocorticoids? Glucocorticoids, which means cortisol, here definitely will be low. There's no doubt about that. And this is the reason why your ACTH levels also will be elevated. And this is the reason for hyperpigmentation in these children and hyperplasia of the adrenal glands in these children as well. So remember, this low melanocorticoids along with low glucocorticoids is the main reason for shock in these patients. Remember, a true decrease only in the melanocorticoids will result only in salt wasting in the urine, but they won't go for shock and crisis. So low melanocorticoids, low aldosterone definitely will result in salt wasting. There's no doubt about that. But this low glucocorticoids along with low melanocorticoids will usually make the patient go for shock and crisis. Usually this neonatal shock and crisis will manifest by 7 to 14 days after birth in this classic forms of, especially the salt wasting forms of 21-hydroxylase deficiency. The glucocorticoid levels that are low might precipitate poor feeding in the children, and that is also going to be one of the main reasons for shock and crisis, and that might also result in recurrent persistent neonatal hypoglycemia, because cortisol is very important for maintaining the serum glucose as well. So you're going to result in persistent hypoglycemia in these children. So what about the adrenal androgens? AA stands for adrenal androgens here. What will happen to the adrenal androgens? Here the adrenal androgens will be increased, which means your DHEA, DHAS as well as androstenedione levels will be very high. So what will be the gonadal function here? The gonadal function will be completely normal, which means they produce normal sex hormones, both males as well as the females. But I told you what will be the next net effect in these children. The net effect in these children will be excessive androgens. Irrespective, leave them. Whether they come from the adrenal glands or whether they come from the gonads, doesn't matter. The net effect is in these children is excessive androgens. But in this case of 21-hydroxylase deficiency, it's coming from the adrenal glands. Obviously, this excessive androgens is not going to be of much problem in case of a male, but it's definitely going to be a problem in case of a female child. So if it's a XX karyotype, this female child will definitely be virilized and they're going to present with DST, that is ambiguous genitalia. This male child, this excessive androgens is not going to be of much effect at birth at least, which means at birth, they'll have a normal external genitalia. There is no doubt about that, which means these children will not have any DSD, because in a male, excessive androgens doesn't make any sense. But in the long run, over time, they can go for precocious puberty. Or in other words, from endocrinologist perspective, I can write it's a early puberty. Clear? That is because of consistent exposure to high androgens which are coming from the adrenal glands in this scenario. So this is what is going to happen, which means that DSD, which means the disorder of sexual differentiation or ambiguous genitalia in 21-hydroxylase deficiency is going to be seen only in female children, not in the male children. That's a very important clue in exams as well. So what will be the effect on external genitalia? Females over-virilized and they present with DSD, which means I can write it's a XX DSD, but whereas males, normal external genitalia at birth. Clear? So there will be no problem in the male children. That is XY will be normal. Only this is a condition of XX DSD, not a XY DSD. So plasma radiant activity and angiotensin II activity, we know very well. Obviously, you have salt wasting here and the patient will be in shock, hypotension and hypovolemic state and crisis. That's definitely going to stimulate the plasma renin activity and angiotensin II activity. PRA stands for plasma renin activity here. So finally, what are the metabolites that will be increased and what are the metabolites that will be decreased? Metabolites that are decreased, we know very well. So deoxycorticosterone will be decreased, corticosterone will be decreased. Deoxycorticosterone you can also write as 11-DOC also, no problem. And aldosterone levels will be low for sure. Cortisol levels will be low. 11-deoxycortisol levels also will be low. But what are the levels that are raised? The most important is the 17-hydroxyprogesterone, which is going to be the most important diagnostic marker for 21-hydroxylase deficiency. But apart from that, your adrenal androgens are also increased, DHAS as well as androstenediones. But please do understand, from now on I can interchangeably use the 17-hydroxyprogesterone and 17-hydroxypregnolone for 17-hydroxy derivatives. And this dehydroepiandrosterone androstenedione, I can also call it as 17 ketosteroids also. So which I have told you in the previous video itself. This DHA and DA4 are androgens, C19 steroids, but they are specifically called as 17 ketosteroids. Clear? The most important source of 17 ketosteroids is the adrenal glands. But the most important source of androgens in males is the testis. That is different. But the most important source of ketosteroids in any person is the androgens coming from the adrenal gland only. So similarly, 17-hydroxyprogesterone and 17-hydroxypregnolone, I can call them as 17-hydroxy derivatives. Which means here, in exam, sometimes they may give the 17-hydroxy derivatives as well as 17 ketosteroids will be elevated in these patients. True statement. Yes, no problem about that. So these are the effects of 21-hydroxylase deficiency. But the problem is, since this being a very, very common enzymatic defect in the world, we have identified multiple subtypes in the same enzyme defect. So like for example, you might have a classic form of congenital adrenal hyperplasia due to 21-hydroxylase deficiency, or you might have a non-classic variety of 21-hydroxylase deficiency as well. So this classic form of 21-hydroxylase deficiency, the things what will happen we have discussed already. But still, it is divided into two forms called salt wasting forms, which is going to be the most lethal form of all, because if we don't treat these children, they are going to invariably die because of crisis. And you have a simple virilizing form without salt wasting form. This is simple virilizing. They only cause DSD or ambiguous genitalia, but they do not cause any salt wasting at all. So this is not lethal, to be honest, but they can die in times of stress. But anyways, so this is not really that much lethal. So how we are going to differentiate between these types? So first, let us see the enzyme activity. So what will be the enzyme activity in this children with different forms of 21-hydroxylase deficiency? So in the most lethal salt wasting form, the enzyme activity will be almost 0, less than 1%. In simple virilizing form, some enzyme will be there, 1 to 5%. In non-classic variety, it will be more than 5%. Clear? But it will be less than what you see in the normal people, but it will be more than 5%. Similarly, whether you will see salt wasting or not, in salt wasting forms, yes, there will be serious amount of salt wasting. In simple virilizing form, you won't see salt wasting, and in non-classic form, definitely you won't see salt wasting. And similarly, what is the presentation at birth? Presentation at birth, they usually present with the XX DSD. We know that. So only female children will be over-virilized. Male children will be normal at birth. We know that, XX DSD. And they will be presenting with adrenal crisis. Because of both glucocorticoid as well as mineralocorticoid deficiency, they will go for overt crisis, which means I can write this as overt crisis. Definite adrenal crisis. Usually they will be coming with crisis at 7 to 14 days after birth. This is a classic timing where they present with crisis. These kind of children, if you fail to identify this condition in the during the birth itself. So what will be the presentation at birth? These children will have only XX DSD, but there will be no crisis because there is no salt wasting. There will be no crisis in these children. But remember, crisis can happen because these people are also having cortisol deficiency. So crisis can happen during stressful times. Like if the patient develops neonatal sepsis or meningitis or some other stressful event, crisis can develop in these children also, but generally very rare. Clear? So they only present with virilization of the female fetus, that is XX DSD. That's all. So what will happen in non-classic forms? Non-classic forms, they will be completely normal. Normal presentation at birth. You cannot identify these children as having congenital adrenal hyperplasia because their enzyme levels are okay, not bad at all. And what about the DSD? I told you it's an XX DSD. It's a XX DSD here. There won't be any DSD at all in the first place here. Similarly, what will happen to the XY karyotype? XY will not have DSD at all, but they are prone for developing this early or precocious puberty. Similarly, here also there will be no DSD, but they can develop precocious puberty or early puberty. Similarly, this non-classic variety XY will not have any effect at all, which means the XY karyotype children will not be affected at all. But can XX karyotype will be affected? Yes. XX karyotype can be affected even though they do not have a DSD at birth, which means there will be no ambiguous genitalia at birth. But because these children at puberty, there will be a surge in ACTH. There will be a surge in ACTH. Whenever there is a surge in the ACTH, all the enzymes will be stimulated. So the substrates will keep increasing. But this 20-hydroxylase deficiency will now start becoming unmasked. Like for example, you have a group of people, you have 10 people. One people, if the limb is completely broken, if it's fractured, obviously they can't run. So that is like a classic forms. So the limb is completely broken. If you ask those 10 people to run in a running race, the person with the completely broken limb, obviously it's very easy to find out at this outright itself because they cannot even move. But if the limb is partially okay, clear, and the limb is not completely broken and only partially fine, so these people, a group of 10 people, when you ask them to walk, they're okay to walk. There will be no problem at all. But when you ask them to run, that is where the person with a deficient limb will start manifesting. So this non-classic variety is like a person with not a completely broken limb, but it's a partial defect in the limb. So till puberty, somehow they walk with the other enzymes because there will be okay average production of the substrates. But during puberty, because of the elevated amounts of ACTH that is coming in the puberty, this entire adrenal process will be accelerated in these patients. Because of that increased load of the substrates in the adrenal gland, this defective 20-hydroxylase deficiency, which is partially defective here, cannot run along with the other substrates, so that now the deficiency will become obvious. Now the adrenal androgens will start increasing. Now there will be unmasking of the deficiency. So because this increased adrenal androgens happen at the time of puberty, these children or these adolescents usually presents with hyperandrogenic features. At puberty or at or post-puberty, they will present with hyperandrogenic features rather than a DSD at birth. Classic forms will have a DSD at birth, that's a female XX DSD, but these females with non-classic variety, they won't present at birth at all, but at puberty or post-puberty, they will coming with hyperandrogenic features. So what are the hyperandrogenic features? They might have hirsutism, acne, oligomenorrhea, that is irregular menses. At the same time, they might be having infertility as well if they come very late. Clear? Along with that, to complicate the issue, 30% of the non-classic congenital adrenal hyperplasia girls will have polycystic ovaries as well. Which means most important differential diagnosis for non-classic type of congenital adrenal hyperplasia is PCOS. So you have to rule out PCOS in these patients for sure. So at the same time, one of the important differential diagnosis for PCOS is non-classic type of congenital adrenal hyperplasia. Especially there are certain areas in the world where there are high incidence of this congenital adrenal hyperplasia. In those circumstances, in those areas, when you think about a PCOS, you also have to rule out a non-classic type of congenital adrenal hyperplasia. This is where your 17-hydroxyprogesterone comes into play, which means 17-hydroxyprogesterone in PCOS will be definitely normal, whereas 17-hydroxyprogesterone in non-classic forms of congenital adrenal hyperplasia will be definitely elevated. So that is the reason why these points are very important to understand. So which means classic forms, XX DSD, salt wasting forms will have salt wasting, simple virilizing forms will not have salt wasting. That's it. And non-classic forms, no salt wasting, no DSD, they'll come with hyperandrogenic features at the time of puberty or post-puberty. That's it. So these are the important things. And what will happen to the 17-hydroxyprogesterone levels? Remember, in classic forms, 17-hydroxyprogesterone levels will be extremely high, very, very high. Usually, the levels will be more than 1,200 nanogram per deciliter. Clear? So this is the usual range, very, very high range. If you see this range, it's a clear-cut diagnosis that is a classic congenital adrenal hyperplasia. Remember, this classic forms of congenital adrenal hyperplasia due to 20-hydroxylase deficiency can be detected by neonatal screening test. So very commonly we do the Hill-Prick test in neonatal screening. So in the neonatal screening, easily it can be picked up because the levels will be very high. So remember, 17-hydroxyprogesterone levels in non-classic varieties usually will be very low. It will not reach the 1,200 mark at all in the first place. and most of them, they escape neonatal screening as well. So they cannot be detected by neonatal screening, which means they can be detected only at the time of puberty or post-puberty, where they usually come with hyperandrogenic features, which is a closed DD for PCOS. So otherwise, they will escape the neonatal screening. So in the neonatal screening, there are some points which you have to know. Obviously, we are testing the 17-hydroxyprogesterone levels only in the neonatal screening because that is the substrate that is immediately proximal to the 20-hydroxylase enzyme. So a deficiency will cause massive elevations of this 17-hydroxyprogesterone, especially in the classic forms. So what are the conditions where you might have a false positive or a false negative values? Remember, false positive neonatal screening is usually seen in the case of children or neonates who are having neonatal sepsis, neonatal infections, or if the neonate is a preterm neonate. Or you can get a false negative values. Very simple. If you have a maternal steroid use. If the mother is using steroid due to some other problem, like for example, a SLE patient, if there is a maternal steroid use, obviously you know this maternal steroid will suppress the ACTH. Once the ACTH levels are suppressed, I told you one of the main reasons why your 17-hydroxyprogesterone levels are elevated is not only because of the defect in this 20-hydroxylase, it's also because of the elevated ACTH. The ACTH levels are suppressed in the mother as well as in the child, in the neonate, in the embryo, because of the maternal steroid use. Obviously, your 17-hydroxyprogesterone levels may be falsely normal. So it may not be elevated because this elevated ACTH is needed for producing this high levels of 17-hydroxyprogesterone. So that will not happen in this scenario. So that's the reason why you might get a false negative result with maternal steroid use, which you have to be very, very careful. Clear? So actually it's very simple to find out in the neonatal period itself. It's not a very difficult disease to find out. But on the other hand, this non-classic type of congenital adrenal hyperplasia is very difficult to find out. So if you are having a suspected case of non-classic congenital adrenal hyperplasia due to 20-hydroxylase deficiency, obviously the first test I will be doing is the 17-hydroxyprogesterone levels. So when will I do? Usually I will be doing at 8 AM. Why at 8 AM? Because at 8 AM I told you in the previous video there will be high levels of ACTH. Usually maximum ACTH and maximum CRH and the maximum cortisol surge, everything is seen at the morning 8 AM. So I told you excessive ACTH is one of the main reasons why 17-hydroxyprogesterone levels are elevated in this patients with 20-hydroxylase deficiency or any congenital adrenal hyperplasia for that matters. So that's why we do a 8 AM 17-hydroxyprogesterone levels. It's a screening. So if the levels are less than 200 or if the levels are 200 to 1500 or if the levels are more than 1500. The levels are more than 1500, straightforward, the diagnosis is confirmed, there is no need for further investigation. It's a NCCH due to 21-hydroxylase deficiency. If the levels are less than 200, it definitely rules out 21-hydroxylase deficiency and non-classic type because it's not possible to have such a low level of 17-hydroxyprogesterone with any degree of 20-hydroxylase deficiency. The patient is having 17-hydroxyprogesterone level of 200 to 1500, it's a gray area. So in this condition, you have to confirm. It's a normal range. So that's what I mean. It's a normal range. So it's a gray area. So you have to do confirmatory test. How will you do confirmatory testing? Give a ACTH stimulation. So I'm going to give ACTH injection and I'm going to do ACTH stimulation with 250 microgram of ACTH intramuscularly. And after 1 hour, I'm going to see the 17-hydroxyprogesterone levels again. This makes a lot of sense, isn't it? Because when you give ACTH, definitely now the substrate production should increase, and even if the enzyme deficiency is very subtle, now it should become obvious because they cannot handle the excessive substrates that are coming due to ACTH stimulating the gland. So the 17-hydroxyprogesterone levels now, if it is less than 1000 or if it is in the range of 1000 to 1500 or if it is in the range of more than 1500. So if it's more than 1500, definitely diagnosis done, that's it. Less than 1000, you rule out the diagnosis, no, not possible. This 1000 to 1500 is again a gray area. So which means these patients who are having a 1000 to 1500 range of 17-hydroxyprogesterone after ACTH stimulation usually will be carriers. Usually may not be true diseased individuals. They will be just carriers having only one gene mutation, or we can call them as heterozygotes. That is the reason why identification of them is again very important because if they marry another carrier, they will result in a child with probably a full-blown congenital adrenal hyperplasia due to 20-hydroxylase deficiency. That is the reason why you need to screen these people with genetic testing. And during their wedding, you have to explain these patients that obviously you should marry only another person with not having this genetic mutation, not a carrier. So otherwise your child have a possibility of getting this 20-hydroxylase deficiency again. So that is why this genetic testing is very important. You have to do just to counsel the patients in fact. So now you know how to evaluate a case of a congenital adrenal hyperplasia due to 20-hydroxylase deficiency. This is really, really important. This is very seriously important, and you have to know each and every bit of this. And what is the treatment? Anyway, you know all these things. So how you are going to treat these patients with 21-hydroxylase deficiency? Treatment of 21-hydroxylase deficiency is dependent on the steroid replacement, obviously. Because here the problem is low cortisol, high ACTH, so you have to suppress this ACTH. This high ACTH is one of the main reasons for majority of the problems. Because we know that this high ACTH is the one that actually virilizes the fetus. Because in female fetus, this high ACTH is the main reason for this excessive adrenal androgens, and that is the reason for virilizing the fetus also. And this high ACTH is the reason for adrenal hyperplasia also. So first you have to suppress the ACTH. How you can suppress the ACTH? ACTH is high because of low cortisol. So you have to replace the cortisol. That's point number one. Second, you have to control the salt wasting, if at all, if it is there. Remember, only the salt wasting forms of classic variety will have salt wasting. Other forms of 20-hydroxylase deficiency will not have salt wasting. So in those conditions, there is no need to correct this salt wasting. But in patients who are having salt wasting, you have to correct this aldosterone loss also, and you have to correct this salt wasting by giving a mineralocorticoid drug like fludrocortisone. So obviously, my treatment will be centered with a glucocorticoid therapy. Remember, this glucocorticoid therapy has tremendous advantages. The first advantage is it's going to suppress the ACTH by feedback. So the suppression of ACTH is very important because it prevents hyperpigmentation in these children if it's a classic variety, because non-classic varieties will not have hyperpigmentation. And it's going to reduce the adrenal androgen output, because I told you that excessive ACTH is one of the main reasons for excessive adrenal androgens. You are going to suppress the ACTH and produce lower adrenal androgens, which will prevent the virilization of the female fetus as well as early and precocious puberty in case of a male child. Obviously, it's going to reduce the hyperplasia of the adrenal glands, because this hyperplastic effect is very important, and you have to suppress that by suppressing the ACTH by giving glucocorticoids. Second, for vital and bodily functions, you need this glucocorticoids, because without cortisol and without glucocorticoids, it's incapable to live. So you will die, and the child will die for sure. So you have to prevent and avoid crisis stages, and for that you need this glucocorticoid therapy for sure. At the same time, the patients might be needing, I'm writing plus or minus, they might be needing mineralocorticoids. Suppose if the child, if that's a condition, if the child is having salt wasting. So if the child is not having salt wasting, you don't need to give this mineralocorticoid at all. The usual mineralocorticoid of choice will be easy, that's fludrocortisone, is the only commercially available mineralocorticoid as of now. So the dose is usually 0.1 to 0.4 milligrams per day. Please do understand there are two important points that you have to know about this fludrocortisone. First point is the fact that usually the fludrocortisone requirement will decrease with age. Generally the requirements will decrease with age. That's a very important point, number one. And the second point is the fact that fludrocortisone may not be needed if the glucocorticoid dose is very high. If the glucocorticoid dose that you are giving is very high, means you don't need fludrocortisone at all, especially if you are using hydrocortisone dose of more than 50 milligrams per meter square per day. So in this situation, you don't need fludrocortisone at all. Why you don't need fludrocortisone at all? Because you know very well hydrocortisone itself possesses some mineralocorticoid activity. For example, every 15 to 20 milligram of hydrocortisone you give is equivalent to approximately 0.1 milligram of fludrocortisone. So that is the reason why when you are using hydrocortisone, especially when the dose exceeds more than 50 milligram per meter square per day, you don't need to give fludrocortisone at all. So these are the two important points with regards to mineralocorticoids. The most important thing is it is not needed if the patient is not having salt wasting. That's the most important. Next thing. So what is the glucocorticoid of choice? So you know there are multiple glucocorticoids which I have discussed in the previous video, but there are three things which we commercially use as a physician. One is the hydrocortisone, which is short acting. Second is the prednisolone, which is intermediate acting. And the third one is the dexamethasone, which is long acting. We know that. But how to choose a glucocorticoid is dependent on the growth suppressing effect of this steroids, because these glucocorticoids are very well known. We have discussed the physiology itself. They are very well known to cause growth suppression in children especially. So that is the reason why you have to choose this steroid very correctly. So first let us see the glucocorticoid effect or anti-inflammatory effect. We have discussed this already, just I am reiterating the point. Anti-inflammatory effect of different steroids. Then what will be the mineralocorticoid effect and what will be the growth suppressing effect of different steroids. So hydrocortisone by default, it's 1. It's a criterion standard. It's a physiological cortisol. It's the pharmacological cortisol. So by criterion standard, it's 111. It's the basic unit. Prednisolone, we know very well, it has more stronger anti-inflammatory effect and glucocorticoid effect, maybe 4, but lesser mineralocorticoid effect, but almost 20 times more growth suppressing effect compared to that of hydrocortisone. Dexamethasone is the most powerful glucocorticoid known. So it's going to have 20 to 30 times more effect compared to that of hydrocortisone, but it has no mineralocorticoid effect, and growth suppression effect is almost 80 units compared to that of hydrocortisone. So that is the reason why we prefer hydrocortisone as the replacement drug of choice in children with 20-hydroxylase deficiency or any cortisol deficiency states in children, because it has a good glucocorticoid action and it has a very less growth suppressing action, and it has a decent amount of mineralocorticoid action as well. Suppose if the child is having salt wasting, this becomes the beautiful choice. So now what is the dose you will prefer? Now I know I'm going to prefer hydrocortisone. What is the dose? General dose I'm going to prefer, even in adults this is the same dose, 10 to 15 milligrams per meter square per day. Usually in adults we prefer approximately around 15 to 25 milligram. That's the usual dose we prefer in adults. In children it has to be calculated based on the body surface area. This dose, because I'm going to prefer hydrocortisone, remember if you wanted to prefer a different steroid in an adult, because in adult you can use dexamethasone also, you can use prednisolone also, no problem. Because in adult the growth suppression is not a problem. So you can use other steroids. So in adults, if you want to know the dose, you can just convert it, because we know the conversion factors which we have discussed in detail already. So just convert it into different steroid based on the hydrocortisone equivalents. So what I have told you now. So this is a hydrocortisone equivalent. This is a hydrocortisone dose that you have to give. So usually hydrocortisone I can prefer giving twice a day or thrice a day. Generally I personally prefer giving thrice a day, but there are regimens which prefer twice a day dosing also. Remember, hydrocortisone 2 to 3 times a day, prednisolone twice a day usually for replacement doses, and dexamethasone usually once a day is more than enough because it's very long acting. So or thrice a day dosing. So if you are giving twice a day, what is the dosage that you will prefer? So 1/3 I'll be giving in the mornings, and remaining 1/4 I'll be giving in the evenings at around 5 or 6 o'clock. Similarly, if you are preferring thrice a day dosing, I'll be giving 1/2 in the morning, and remaining 1/4 I'll be giving in the afternoon, and the remaining 1/4 I'll be giving in the evening. So you can clearly see that whatever may be the dosing regime, the maximum dose should be in the morning. That is because I have to mimic the physiological diurnal variation of cortisol. The cortisol tends to be maximum in the morning. We know that. The CRH, ACTH, cortisol, all these things tend to be maximum in the morning, and that is the reason why I want to give maximum dose of cortisol in the morning. Hydrocortisone in the morning. And this is also very important because ACTH secretion also will be maximum in the morning, and that ACTH is the problem in this patient. So to suppress ACTH that surges in the morning, I need high dose of glucocorticoid in the morning. So that's why I prefer this dose even in adult patients for any patient with cortisol deficiency. Clear? So when you need extra dosing, and this is a very important point, even in adults this will apply. So I'm not going to discuss again. So you need something called a stress dose. What do you mean by stress dose? In illness states like fever, infection and all, you might be needing extra dose of steroids. Because these steroids are very important for catecholamine action because of their permissive ability. So when the catecholamines rise, the steroids also have to rise. Then only you will produce a stress response and the patient will survive. Otherwise, the patient is prone for dying out of crisis. So that is the reason that giving stress dose is really, really important. The first one is if the patient is having very mild fever of just somewhere around 38 or 38.1 degrees Celsius or just having a simple cough, you really don't need any additional stress dosing. You can just wait and watch. If the patient is having significant amount of fever, or if the patient is having acute respiratory illness, fever in the sense more than 38.5 degrees C, or if the patient is having acute respiratory illness, which is very common in children like pneumonia or other viral respiratory illness. So in these conditions, it's better to give double dose of what you are giving already for at least 3 days. If the patient is having very high grade fever, or if they look visibly very sick, so in this circumstance, it's better to give triple dose of what you are already giving for 3 days, followed by double dose for 3 days. So this is what we refer to as stress dosing. Clear? Where you need extra amount of cortisol. In the sense you are giving hydrocortisone extra doses. Suppose if the patient is in shock, or the patient is having severe vomiting or diarrhea, this is a very danger sign. The patient might die out of simple diarrhea and vomiting. So in this condition, it's better to give parenteral hydrocortisone or IV hydrocortisone with a dose of 100 milligram per meter square per day, high dose, till the shock is corrected. This will be followed by usual routine oral stress dosing, what I have told a couple of minutes ago. So, but for shock, vomiting and diarrhea, you need parenteral hydrocortisone dose of approximately 100 milligram per meter square per day. And once the shock is corrected, the vomiting and diarrhea is corrected, you can go back to the routine stress dosing. Clear? So this is really important once again to understand. Clear? Fine. So let us move on and discuss the final part of this 20 hydroxylase deficiency, that is prenatal treatment, or otherwise I can call it as prevention of this virilization of the female fetus. Because we know this female fetus are generally virilized by these excessive androgens. During that 8 to 13 weeks marks, that's the most crucial time for external genitalia to develop. So whether you can avoid or not, yes, you can avoid. And these experimental studies and many countries with high carrier rates of this 20 hydroxylase deficiency patients are generally following this protocol what I'm giving. But in general, prenatal treatment is approved in those countries, but overall in the world, it's very controversial. So how we are going to treat? So the idea is to suppress the fetal ACTH as soon as possible. And especially during that 8 to 13 week mark, so where the fetus is having a maximum chance of getting virilized because of this high ACTH and high adrenal androgen output. So you have to suppress that ACTH in the fetus. So you have to choose a steroid that suppresses the ACTH in the fetus by crossing the placenta. So for that regards, dexamethasone is the best steroid. Which the reason is because dexamethasone has very, very low cortisol binding globulin binding. So because of that reason, dexamethasone can cross the placenta very easily. On the contrary, hydrocortisone cannot be used in this case because it has high binding with cortisol binding globulin, and the amount that is going to reach the fetus is going to be very low. So on crossing the placenta is also very low with hydrocortisone. That is the reason why we are going to prefer dexamethasone. Clear? So when you have to give, as soon as the pregnancy is confirmed. As soon as pregnancy is confirmed. But whether you will give this dexamethasone for all patients? No, not at all. So which means there should be some entry criteria. So the patients are eligible to get dexamethasone only if both the parents are carriers. If both the parents are carriers, so then the mother will become eligible for this dexamethasone therapy. Clear? So then only, husband and wife both should be carriers. Then only the mother will be eligible for dexamethasone therapy. So you start giving dexamethasone as soon as the pregnancy is confirmed. Usual dose is 20 microgram per kilogram per day. So to suppress the fetal ACTH. So now, how long you will continue? So whether you can continue or not, continuation or discontinuation depend on certain criteria. Continuing dexamethasone is needed if the child is XX karyotype, because you have to do amniocentesis or chorionic villus sampling, and you have to see the karyotype. If it's the XX karyotype, plus the child should have 21 hydroxylase mutations. So then only you can continue. Otherwise, you no need to continue. You can discontinue. In case if the child is XY karyotype, there is no need. After birth, you can treat. Or if the child shows no mutation in the amniocentesis or chorionic villus sampling during pregnancy, done during pregnancy, no mutation in 20-hydroxylase enzyme. Because even if both are carriers, this autosomal recessive disorder, there is only 25% chance that the child will be having the mutation. Clear? So it's not a must that they should definitely, all these children should have the mutation. So if there is no mutation in 20-hydroxylase, I mean especially homozygous mutations, then you can stop the dexamethasone therapy in the mother. So you can continue for indefinite period also, but most importantly, that 8 to 13 weeks period is the most important. That is the time where the female fetus generally gets virilized, and that is the time where you have to definitely give this dexamethasone for sure. So but starting as soon as the pregnancy is confirmed. So clear? So even those giving steroid, why it's controversial? Because of many reasons. One, early exposure of this children to steroids like dexamethasone, to a powerful steroid, might result in cleft palate and cleft lip. So there are some studies which proved that early exposure to corticosteroids may result in these disorders. And second thing, you have to do chorionic villus sampling or amniocentesis, which is having a risk of fetal demise as well. So that is the reason why certain guidelines don't approve this, but still countries where there is very high incidence of this 21-hydroxylase deficiency, they generally follow this protocol. Clear? So with this, we have completed the 21-hydroxylase deficiency, and we are moving on to the other defects like 11-beta-hydroxylase. Let us finish it off as soon as possible. So clear? So remember, 11-beta-hydroxylase deficiency means I mean only this particular enzyme. Clear? So I mean only this particular enzyme. Aldosterone synthase is intact. So there is no problem in that. So what happens in 11-beta-hydroxylase deficiency? Point number 1. So obviously the cortisol output will be seriously impaired. So since the cortisol output is seriously impaired, it is going to stimulate the pituitary, and the ACTH levels are going to be very high. If the ACTH levels are very high, they are going to produce hyperpigmentation. At the same time, not only hyperpigmentation, they are going to produce trophic effect on the adrenal gland, resulting in adrenal hyperplasia. Next, obviously, the substrates that are proximal to the defect will increase, especially with the effect of both enzyme defect as well as high ACTH, which is going to stimulate the other pathways. So your deoxycortisol level will be high, your 17-hydroxyprogesterone will be high, and other substrates also will increase like progesterone, pregnenolone, and 17-hydroxyprogesterone. And obviously, these substrates that are increasing will result in increased production of adrenal androgens as well. So in this patient, you are having increased production of adrenal androgens for sure. So this is not a problem in the, like male child. So, but this is a big problem in the female child. Let us see in some time, like how we have seen in the 21-hydroxylase deficiency. At the same time, these children will be having high levels of deoxycorticosterone, but they will be having low levels of corticosterone and aldosterone. You might be thinking why, like obviously this high progesterone means there should be high deoxycorticosterone and there should be high corticosterone, 18-hydroxycorticosterone and aldosterone as well. So why they are suppressed? So let us see. Remember, in fetal life, this deoxycorticosterone is definitely very good mineralocorticoid, but not very powerful like aldosterone. I'll tell you, in infancy, it will not be sufficient. But in early neonatal period and in the fetal life, this excessive deoxycorticosterone is more than enough as a mineralocorticoid, and it's going to produce hypertension and salt retention in the female child. Hypertension and salt retention in these children. So because of this hypertension and salt retention, so that will suppress the renin activity by feedback. So this is, which means it's a low renin hypertension. So they will suppress the renin activity, and which is going to in turn suppress the angiotensin II activity. So because of the low angiotensin II activity, your aldosterone synthase enzyme will be seriously suppressed. Remember here, the aldosterone synthase enzyme is not deficient, rather it is suppressed by the suppressed renin-angiotensin system. So since the angiotensin II is suppressed, aldosterone synthase enzyme activity will be very low. Because of that, the conversion of deoxycorticosterone to corticosterone and the conversion of corticosterone to 18-hydroxycorticosterone and further conversion to aldosterone will be very low, reducing the levels of corticosterone and aldosterone for sure. So this is the basis behind this biochemical picture that you are going to see later. But remember, since this 11-beta hydroxylase enzyme is purely an enzyme of adrenal steroidogenesis, your gonadal steroidogenesis will be completely normal. Gonadal steroidogenesis will be completely normal and there will be no problem at all. So that's what I'm going to write here. So what will be the inheritance? Inheritance is surely autosomal recessive. There is no doubt about that. All are autosomal recessive. So gene will be CYP11B1. We know that. And the chromosome is chromosome number 8. Here the mineralocorticoid effect. Mineralocorticoid levels will be actually increased. And what is the mineralocorticoid that is increased? It's only the deoxycorticosterone. 11-DOC, that's the only mineralocorticoid that is increased. But actually, your corticosterone and aldosterone levels will be suppressed. Clear? They will be reduced. That is reflecting the angiotensin activity. Clear? But you have to understand the fact that these children at birth, they will be presenting with hypertension. That is due to excessive deoxycorticosterone activity. Definitely they will present with hypertension at birth at least. But in the early infantile period, even though deoxycorticosterone levels are increased, but that is not so powerful like aldosterone. So as the child grows, as the like infant grows over time, this deoxycorticosterone alone will not be enough and they will be going for salt wasting in the early infantile period. So, but at the time of birth, many of these children, in fact all of these children will be having hypertension because of the elevated deoxycorticosterone levels. And what about the glucocorticoids? Glucocorticoids, very well it's going to be reduced. There is no doubt about that. Cortisol will be reduced. And because of that, ACTH will be high, and that is the main reason for hyperplasia and hyperpigmentation. And that is also the main reason for this excessive adrenal androgen output as well. So what will be the adrenal androgen output? It will be very high. So now, what will be the net effect? So because of low glucocorticoids, they are prone for crisis. They can go for adrenal crisis, especially in times of infection and stress. And they can go for recurrent and refractory neonatal hypoglycemia, and they are also prone for developing these problems like poor feeding and lethargy in the child. Clear? So if the adrenal androgens are high, so what is going to be the effect? But let us compare and contrast with the gonadal function also. Here the gonadal function is completely normal. So couple with this. So you are going to have increased androgens in the body. Clear? You are going to have increased androgens in the body overall because gonadal output is normal if it's a male child, and adrenal androgens are increased. Coupled with that, even in a male child or a female child, the overall androgen output is high. So these excessive androgens, in a female child is going to cause DSD. Because of that, this 11-beta hydroxylase deficiency is also an XX-DSD. It's going to cause ambiguous genital in the female child, which means it's going to cause over-virilization of the female children. But in a male child, there will be no problem. So the male child will be normal at birth, there will be no DSD at birth, and they will be normal at birth, but still because of the excessive androgen output from the adrenal glands, over time they are prone for early puberty or precocious puberty. Exactly like what you saw in the 20-hydroxylase deficiency. But one thing, they don't have salt wasting. Usually they are having hypertension at birth. That's the most important difference. Apart from that, this is also a form of XX-DSD and not a XY-DSD. Here the male children will usually be normal at birth. Only the female children will go for virilization and ambiguous genitalia. What are the effects on external genitalia? Let me consolidate again. Females XX, definitely DSD. Males XY, normal. No DSD. No ambiguous genitalia. Clear? So ACTH increase, we know that. What about the plasma renin activity and angiotensin II activity? We know that at birth at least, we have clearly seen this high deoxycorticosterone is going to cause salt retention and hypertension, and for that reason your renin and angiotensin activity will be low. So I can write that the plasma renin activity and angiotensin activity will be suppressed. This is quite opposite to what you saw in the 20-hydroxylase deficiency, where it will be increased usually. What are the metabolites? Metabolites that are increased obviously is the 17-hydroxyprogesterone. There is no doubt about that. But even though the levels that are raised will never match the classic form. So classic form will have more than 1200. Definitely it will be raised here, but it will be less than 1200 only. So there are some other things that are raised like deoxycorticosterone, one of the most important compounds here. At the same time, your 17 ketosteroids will be elevated, which means 17 hydroxy derivatives are elevated, 17 ketosteroids are also elevated here, like dehydroepiandrosterone and androstenedione. Both will be elevated, and DOC also will be elevated. What are the levels that are suppressed? Obviously, cortisol levels will be suppressed, and your corticosterone levels will be suppressed, and aldosterone levels will be suppressed. Aldosterone levels will be suppressed. So these are the metabolites that are generally suppressed. But deoxycorticosterone is very important to know here. That will be increased.